Good evening. I'm Samantha Hunter, and you're watching a CSB show on Channel 333. Tonight, we have a very important segment about supporting our paramedics and their clinical skills, more specifically, pre-hospital IV fluid therapy. Despite the controversy of the topic leaking into the media, it's important to remember that this is an essential practice, as goal-directed fluid resuscitation, especially in circumstances with long transport time, is essential for patient health in their time of need. When indicated, normal saline, which has nothing ordinary about it, can increase a patient's interstitial and intravascular fluid level. Of course, this isn't the standard treatment for everyone who gets into an ambulance, but what about those who really need it? What about those patients suffering from a considerable degree of volume depletion, which could be caused by numerous emergencies, both traumatic and non-traumatic? Infusion of isotonic saline is indicated for both of these events. So why shouldn't our paramedics provide the best care they possibly can? Joining us tonight are a few reporters and paramedics, live from disasters and unfolding incidents, to discuss the importance of pre-hospital IV fluid therapy with the goal to prevent the worsening of serious conditions. Now, I think I've talked enough and it's time to hush down. Let's hand over to the first of our paramedics tonight. All yours, Hayley.
Good evening, Samantha and viewers. Today, I was fortunate enough to take part in the assessment and treatment of a critically ill patient here in Brisbane, and I administered the fluid therapy in the pre-hospital environment. This patient presented with hemodynamic instability with a systolic blood pressure of over 90 millimeters Hg, as well as a fever and tachycardia. There was a potential for sustaining multiple organ failure, and we were fearful that she wasn't going to make it through. Now, it is understood that sepsis is due to a localized inflammatory response that has been triggered by an infection within the body, and it may present in various ways depending on the site of infection. However, it was clear we needed to administer 30 milliliters per kilogram of fluids intravenously immediately within the first hour. And this is because with every hour of delay, survival decreases by 7.6%. Once the IV fluid was administered, the patient's temperature markedly decreased and there was a significant clinical improvement seen. This is not to our surprise though, as numerous studies have been done with clinical improvement being observed. In an observational cohort study done by Seymour et al., who looked at pre-hospital intravenous access and fluid resuscitation in severe sepsis, found that the administration of any pre-hospital fluid was associated with reduced hospital mortality compared to no pre-hospital fluid. Now, this reduction may be caused by the fluid decreasing interleukin-6, a pro-inflammatory cytokine that plays a role in sepsis. A study done by Brandt et al. Observed just that. A reduction in IL-6 levels in patients when arriving in hospital. It was found that of the 345 patients, 26% were given pre-hospital IV fluid and 74% were not. Now, I know that is a small percentage that was given the fluid, but this is because IV fluid in the pre-hospital environment is controversial due to the risk associated with it. Nevertheless, it was observed that there was a relative decrease in IL-6 at hospital arrival in those receiving a pre-hospital fluid. This indicates that the inflammatory response is decreased by the IV fluid and therefore is an essential practice for the pre-hospital environment. Jones et al. Interestingly found that Lane and his colleagues reviewed 16 published studies and found that roughly half of all of the patients admitted to the hospital with a severe sepsis diagnosis arrived by ambulance service. This volume reiterates the time-sensitive care that us paramedics provide to patients during life-threatening situations. So I can safely say administering IV fluid to a patient that has potential organ failure, otherwise known as sepsis, is essential to give the patient the best chance of survival. So Andrew, I'll hand it over to you for you to give us an insight into the importance of IV fluid administration with burn patients. Thank you.
Thank you, Hayley. And I can confirm that it's hell on earth here we're reporting to you from today. There's police, ambulance, and firefighters everywhere. Everything is on fire and a lot of people have sustained burn injuries. Fortunately, in a ray of good hope, I can report to you that our brave paramedics have been out there in the field today saving lives with the assistance of this. Sodium chloride administered via IV therapy, 0.9%. To our viewers at home, Did you know that pediatric patients that sustain burns to more than 10 to 15% of total body surface area require IV fluid resuscitation as soon as possible? Whilst this reporter has come to learn that the basic management principles are similar to that of adults, there's a different pathophysiological response in children in which the cascade of events that occur following a burn are more exacerbated. Therefore, it is no surprise to learn that there are past major studies that have shown a reduced mortality rate when prompt IV fluid resuscitation is given to children with substantial burns. And it's furthermore no surprising, the more recent publications have backed this up as well. Whilst there are some precautions that our incredible paramedics need to take in administering this particular drug, such as excess administration, which can lead to more acute conditions such as pulmonary edema or acute respiratory distress syndrome, or other things such as renal or cardiac precautions. When administered judiciously, the benefits far outweigh the risks, and therefore we should not be stopping our brave paramedics from doing the brilliant job that they're doing by taking away something that's so essential for them to save people here today. But what about mum or dad, one may ask? What about for adults? Well, I can let you know that we can't just leave them hot, high and dry and at risk of hypovolemia. Did you know that a recent study was conducted into the pre-hospital administration of IV fluid therapy in the Alfred Hospital, in which our cousins in Victoria were using the same protocols that the Alfred was using out in the field? And would you guess what? Better patient outcomes were obtained through the use of the same principles that the Alfred Hospital was using when they were using in the back of the ambulance. Again, there are precautions that our brave paramedics out there are needing to take to do this, but in order to save lives here today and elsewhere, they need to be able to continue doing this, and again, the benefits far outweigh the risks. And therefore, with that being said, wait, what's happening? I have fires coming. It burns! Run! Over to you, Callum!
Thanks, Andy. My name is Callum Lockett, and I'm here to discuss the benefits of using 0.9% sodium chloride fluid therapy in the treatment of dehydration, heat exhaustion, and electrolyte imbalances. With the heat from today's incidents, these interventions are vital in making sure that those affected don't become dehydrated, the symptoms of which can include extreme thirst, dark-coloured urine, fatigue, dizziness, and confusion. Dehydration can also lead to hypovolemic shock in extreme cases due to the lack of fluid in the bloodstream. To begin with, for decades, 0.9% sodium chloride has been used intravenously in the rehydration of those who have lost significant fluid, either from sweating, urination, or through lost blood. With the heat from today's incident, fluids are vital in the rehydration of those affected. A 2006 study from Medicine and Science in Sports and Exercise, or MSSE, found that compared to oral fluid intake, the use of IV 0.9% was significantly more beneficial in the rapid increase of plasma volume in those who had significant physical exertion. The benefit of an increase in plasma volume is that it increases blood pressure, as well as allowing transportation of more waste products in the blood. Another study by MSSE in 2012 showed the same findings, with an addition of glycerol improving recovery rate after a 40-kilometre cycle. One of the major effects of dehydration is that of electrolyte imbalances, specifically hyperkalemia, an increase in the concentration of calcium in the blood, the effects of which can include abnormal heart rhythms, muscle cramps and spasms, headaches, nausea, and a decrease in bone density, as well as central nervous system impairment and kidney function if left too long. The aim in the treatment of electrolyte imbalances is to decrease the concentration of minerals in order to bring values back to normal parameters. Significant evidence has shown that the most effective method of doing this is through the use of IV 0.9% sodium chloride in order to increase plasma volume and decrease mineral concentration. The action of increasing plasma volume has also been shown to be beneficial with diabetic conditions such as diabetic ketoacidosis and hypoglycemic hyperosmolar state, due to the fact that the concentration of minerals as well as ketones is reduced in the blood, resulting in levels going back to normal. In terms of HHS, the use of 0.9% sodium chloride in conjunction with insulin showed a significant reduction in BSL as well as an increase in hydration, showing a positive response compared to just using insulin. In review, The use of IV 0.9% sodium chloride has been supported to show significant positive effects when used in situations involving dehydration or electrolyte imbalances, resulting in improved outcome for the patient. We will try to get back in with Andy shortly to see if he's alright, but for now, here's Rory and Stuart. Thank you.
Thank you, Cal. My name is Rory McHugh. I'm here at this morning's crash site where multiple cars were involved in a high-speed accident. I'm live on Zoom with the lead paramedic, Stuart Martin, who is currently at the Royal. Now, thank you for being with me here, Stuart, to go over exactly what took place this morning. If you could just start with explaining to us, in what state did you find the people or peoples involved?
Yeah, it was a bit of an abattoir, Rory, to be honest.
Yeah, that's okay. Thanks for that. But I noticed there's still a lot of blood at the scene. What's happened there?
Yeah, well, with so much blood loss, there are quite a few things to consider. In trauma patients, it's important to be wary of not letting the patient slip into shock or hypovolemic shock, which is not enough blood, and that can occur in major blood loss. To avoid this, we try to maintain an appropriate blood pressure so that the patient can still maintain adequate perfusion to their organs and tissues. As part of the QAS, I am indicated by protocol to treat a patient suspected of hypovolemia with 20 mils per kilogram or 0.9% saline, basically salty water, as well as doing other trauma management strategies such as tourniquets and bandages. But knowing how much fluid to give and what target systolic pressure I should be getting is a difficult thing to gauge. But essentially, if I can feel a radial pulse down there near your wrist and you seem jolly enough, I'm happy with that. The consideration here is that too much fluid can cause more bleeding by loosening the clots that are formed at the original site of bleeding. Think of it as blowing the cork out of a hose.
I see. So is that it though? There was just a few cuts and grazes?
Nah, not this morning. There are definitely a few fractures, and one woman had suffered quite a significant head knock, which was an important consideration when providing fluid to her. With a traumatic brain injury, we need to make sure that a higher systolic pressure is targeted closer to normal systolic pressures, just so we know that the brain has been adequately perfused. But in the absence of traumatic brain injury, I like to use a practice known as permissive hypertension, which is allowing the patient to remain below normal levels of blood pressure than a healthy person, just as long as their level of consciousness and their pulse is appropriate. I find it advantageous to administer crystalline fluid in 250 ml increments just to monitor them a bit more gradually.
Fair enough. And this shock that you're referring to, what does he mean? I don't exactly think that a cloud in no cupboard could be giving a fright to anybody here this morning.
No, it's shock's just one of those things that the body does. It's one of their responses. It's a broad term that basically means that the body's not getting enough circulation and it starts to shut down. This can be caused by several factors, like an allergic reaction or low levels of blood, as you saw here this morning.
Okay, so like today with all the external bleeding?
Yeah, but also things like internal bleeding or severe dehydration or vomiting can reduce our blood's volume. And although people can often view the ambulance service as just a shipping service for hospitals, one study has shown that we can have a positive impact on the in-hospital shock index, reducing as much as 7% when we administer a litre of fluid in the field. So yeah, it kind of makes sense if anyone does not have enough blood and is exhibiting the signs of shock or low blood pressure, why not give them a top-up of this 0.9% crystalline fluid just to make that pressure rise and that blood be more effective.
Okay, so this fluid really is quite good for you.
Well, yeah, I certainly think so. It's still being thoroughly researched, but one study on over 1,200 patients has shown that it does decrease in-hospital mortality, even though they actually had lower systolic blood pressure. It goes to show that fluid therapy and resuscitation is a fairly common problem, but certainly for today's injuries, I was indicating.
Very interesting. Well, thank you, Stuart, and to all the paramedic workforce for your tireless efforts. You make it sound as if we should be filling up our cars with this gas saline.
Cool.
Well, there we have it, guys. Pre-hospital IV fluid therapy has many benefits by the sounds of it, all starting from increasing intravascular and interstitial fluid levels. When used correctly, this fluid has the potential to save many lives. Of course, there were limitations mentioned, such as fluid overload causing acute pulmonary edema and respiratory distress syndrome, renal and cardiac conditions, and electrolyte imbalances. But to put it quite simply, it sounds like fluid resuscitation is not harmful in moderation, right? Now, that marks the end of this thing. Wait, I've just heard that we have an update on Andy. Thankfully, our paramedics have saved him. With what, you may ask? You guessed it, good old sodium chloride. Thank you to all. We hope you have a great evening.